I want to give you a little insight into ultrasound in undergraduate medical education. So one of the things is when a medical student comes to you, it's really hard to describe in words something that a picture will tell them almost instantaneously. So questions like, how do you explain cirrhosis to a medical student is very challenging. You know, cirrhosis is hard to understand. If you understand cirrhosis, then you probably have read a little bit about it. You understand about fibrosis and toxins and all of this stuff. But with ultrasound, you can show them pictures and say, okay, well, here's a normal liver. See all the structures in there, and I can tell you what each one of those structures are, the portal veins, the hepatocytes. You can see all of that. You can see how it relates to the kidney, and it's should be a little bit brighter than the cortex of the kidney. And I can tell you exactly why that happens. And then in cirrhosis, you start having toxins that come in, and they're injuring the liver, and the liver is becoming fibrosed. So it starts shrinking down. Those normal hepatocytes start getting smaller and smaller because they're getting weaker and weaker, and it gets stiffer. The liver gets stiffer because of all this fibrosis, and so blood doesn't want to go into it. And if blood doesn't want to go into the liver, it can't get detoxified. So that's why you start acting a little crazy when your blood's not getting detoxified. Your ammonia starts going up, right? Because the liver's not doing its job because blood can't get into it. And if blood can't get into the liver, it starts backing up, and that's why you start having ascites or fluid in the abdomen. So it's really easy for me to describe that to you when I can show you a picture of normal and abnormal, and I can show you how the liver is affected by cirrhosis, and I can show you the side effects of that, like the ascites building up in the abdomen. And that in itself is very useful, but then you can take it a step further. So how do you know the intermediate stage? What about fatty liver? Well, fatty liver, you know, is very hard for me to describe to you. And I say, well, it's kind of like cirrhosis, but not. And you say, well, how is it not like cirrhosis? And I say, well, it's pre-cirrhosis. It's toxic liver, but they don't have the ammonia problems yet. And you say, well, how do you know that? I say, well, the liver is normal size, but you can see the architecture is starting to disappear. You're starting to lose that normal architecture, but it hasn't shrunk down, and it's not as stiff as a cirrhotic liver. So the blood is still going in there, and so you don't get the ascites and your ammonia doesn't go up. But you can see this on ultrasound, and you can tell your patient, hey, the things that you are doing to your body are causing you problems, and you will develop cirrhosis if you keep doing them. So not only does it help me explain it to you, it helps you explain it to your patients, which is kind of a cool thing. And why we use ultrasound to help you understand anatomy and physiology. So here's another one with physiology. So me as a medical student, when somebody said, hey, that's a mid-systolic click and that's or a holosystolic murmur, I was like, I'm not sure I know exactly what you're talking about. But with ultrasound, I can hear it, but I can also show it to you. I can show you where the valves are closed and show you systole and diastole, and I can show you that there's a regurgitant murmur, right? Regurg across this mitral valve, and I can say, okay, that's mitral regurg. Now listen to that sound, and you make this visual auditory connection. That way you're learning on multiple levels, right? So we learn best when, you know, if we're learning how to spell, we learn best when we spell it out loud and then we write it down. All right, or we take notes while somebody's talking. Well, with ultrasound, I can show you and I can tell you and I can let you listen, and hopefully it makes more sense when you get there. And then I can even show you more about it. I can show you how fast that velocity is with ultrasound. I can show you, you know, how much blood's going through there, and then I can teach you about other things about physiology, such as pulmonary hypertension, things that are almost amorphous when you're trying to explain it as an educator. You're like, how do I explain pulmonary hypertension to you? And how do I explain diastolic dysfunction? So you're on the wards as a medical student, and you see the resident, and they say, okay, this patient's got classic CHF. And you let's give them a bunch of Lasix. You give them Lasix, and all of a sudden now they're hypotensive. And you're like, well, why are they hypotensive? Well, you know, it may be because they have diastolic dysfunction. And I didn't really understand diastolic dysfunction, I have to be honest with you, until I started doing ultrasound. And then I can understand what it meant. So I can look at the ventricles, and I can see that there's active relaxation of the left ventricle. So it's pulling blood in. But if the heart has to hypertrophy because the systolic blood pressure is high over a long period of time and gets real thick, then it can't fill with blood. So it's not actively pulling blood in. And so it's having to passively fill that thickened chamber. And so if I give them Lasix, if I give this person with hypertrophic cardiomyopathy, if I give them Lasix, they don't have preload to fill their ventricle. If they don't have preload to fill their ventricle, they're going to become hypotensive. So if you think you got heart failure due to diastolic dysfunction, you don't give them Lasix. You give them afterload reducers. You lower their blood pressure. So it's very different. And with ultrasound, I can show you the difference in the physiology a whole lot easier than I can try and describe it to you, which I try to describe it to you, but up here on the screen, I can point it out and you go, I kind of understand what you're talking about. So our goals for point-of-care ultrasound are to diagnose patients. But our goal of ultrasound and medical education is make you better doctors. All right? We want you to understand anatomy, want you to understand physiology, want you to understand the differential diagnosis process and why some things may be more likely than other things, even if they don't seem to be initially. And so we use ultrasound as a tool to help you understand traditional medical education. And then we want to do this over time so that we help the traditional educators teach you better. And so that's the journey we've been on for a few years now, and y'all are the product of. And it's a pretty unique educational program. This is not in every medical school, and it's certainly not in the depth that we're doing with you. Most places don't use it as an educational tool. They're still in that point-of-care ultrasound mindset. So there are physicians out there, emergency physicians typically, and they're training medical students on how to diagnose a pericardial effusion or how to diagnose a pleural effusion or a abdominal aortic aneurysm. But that's not the point for you guys. The point for you guys is for you to understand physiology at work, anatomy, relative anatomy. How does the kidney relate to the liver? How does the kidney relate to the psoas muscle? So if you had a kidney infection, why does it hurt when you lift the leg? That's the things we want you to get out of this. And so it's very unique. You guys are in a unique setting because this is a distributed medical school, the 8th largest in the country. So, you know, it's a challenging program for us because there's so many of you, but it also lets us have lots of resources. And hopefully by the time you get done, you'll realize how different your medical education is when you're around residents from other training programs, other medical schools, when you're in residency. So let's talk about point-of-care ultrasound. I mentioned it several times now. So what exactly is point-of-care ultrasound? So this all started with the concept of emergency ultrasound. Emergency ultrasound was a new technology ultrasound. It was non-invasive. We could use it on patients right there at their bedside, and this patient was dying. So if I could take the ultrasound transducer and I could put it on there and I could find that life-threatening condition, I could treat it right at bedside, that patient should have a better outcome than if I waited for a radiologist or I did some other test and the results were delayed by minutes or hours. And so emergency ultrasound grew out of that concept of let's use ultrasound to diagnose an emergency right now and then help the patient get better. And so they were usually yes or no answers. So is there a pericardial effusion? Yes, no. Because if there's no pericardial effusion, it's not pericardial tamponade. Is there a baby in the uterus? Because if there's a baby in the uterus, then it's not a baby outside the uterus or an ectopic pregnancy. Does this patient have gallstones? Because if they didn't have gallstones, it's probably not cholecystitis. And so it's a yes or no kind of binary question. And that's the way a lot of this started out, and that's the way a lot of clinicians still practice ultrasound in their clinical practice. That's the way they use ultrasound in their clinical practice. There's a lot of terminology, and it gets kind of mixed up. What I just told you was really emergency ultrasound. You're using ultrasound at the bedside for that emergency patient. But it's really grown past those yes or no answers and out of just a pure emergency diagnosis. And we really talk about clinical ultrasound or clinician-performed ultrasound. And that's the term I really like because all of us are clinicians, or we will be clinicians, and we use ultrasound, and we probably use it a little different way, each one of us, and that's okay, as long as it's making us better doctors. Point-of-care ultrasound is the one you see mostly in the literature, and it's a really good term because you're using it right at the point of care. You're making a decision based on the ultrasound and affecting their treatment, so that's a great term, and I don't have any problems with that. It just seems like clinical ultrasound or clinician-performed ultrasound sounds a little bit more encompassing to me. But we contrast this to traditional sonography. So traditional sonography is very different than what we're doing. And they don't exclude each other. One of the myths that you have is that if you do a point-of-care ultrasound that you can't do a radiology-performed ultrasound, and that's not true. That is completely false. It's a different exam. It's got a different billing code. It's paid for differently, and they don't eliminate each other. And so there's no reason why you can't do both of them on your same patient. there is no problem with me in the emergency department if I do a point of care ultrasound and I say, hey, they got gallstones and they got cholecystitis, and the surgeon comes down and says, well, I'd like the radiologist to repeat this. It doesn't hurt me at all. They're getting information that I may not be giving them, or they want some confirmation before they take them to surgery. I have no problems with that. And billing companies have no problems with that, and Medicare has no problems with that. So that's fine, because they're doing different things than we are. We're trying to answer a specific clinical question. We have a patient in front of us. We have a differential diagnosis that has like 8 things on it, and we're trying to narrow those differentials so that we're thinking about less things. So the only reason for us to ever use an ultrasound on our patient is if we have a clinical question. Now, sometimes when we're learning, we just go scan somebody. But if you just scan somebody without having a clinical question or a clinical probability of something being the problem, you run into the same thing that a radiologist is doing, right? You don't have a clinical context to put your ultrasound in. And the way that we're very good with our ultrasound skills is by putting in that clinical context. We have a very good idea of what's wrong with the patient, and then our ultrasound confirms it. All right? And if we don't use it that way, then we're blinding ourselves, and our ultrasound skills are not going to be as good. All right? So radiologist is like that. They don't always know what's going on with the patient. We just put down on the requisite, abdominal pain. Well, that doesn't narrow it down. Is it right upper quadrant abdominal pain? Do they have a gallbladder already? Has it been taken out? They don't know all of those things until they look at the images. Whereas we already know that because we can ask the patient. And even while we're doing the exam, we can still ask the patient. We can start narrowing it down even further by talking to the patient. They do the entire organ system when they do an ultrasound. So if you order an abdominal ultrasound, you don't get just a gallbladder ultrasound. You get a gallbladder, a kidney, right and left. You get the liver, the spleen, the pancreas, the bladder. And oftentimes you get the aorta and the IVC too. They're thrown in but charged for those. So a little different. But you get in a survey in the entire organ system. Well, if we're looking at somebody that comes in we think has gallbladder problems, we're not going to do all of those things. We're going to look at the gallbladder, and if it's not the gallbladder, maybe we'll do something else. But if it is the gallbladder, we stop. So we are only looking to answer specific clinical questions. They're giving us a survey of the entire organ systems. They don't have clinical context oftentimes to help them gauge whether they're right or wrong on their ultrasound, whereas we do. They do a complete exam. That's a billing term. This is why we can both do this. We do a limited ultrasound. So we can do limited ultrasounds all the way up to the point until a complete exam is done. So what's a complete exam? Well, it could be a complete ultrasound, or it could be a CT scan. So you can do as many fast exams as you want. That's a limited exam until the CT scan's done. And then they say, well, you shouldn't be doing fast exams now because that's a less accurate test, and you've already put them through the truth machine, so that ends that billing. Okay? So it's very different. We're looking for very focused things. So are there gallstones? Is this cholecystitis? Whatever it is, they're looking for a wide range of diagnoses, including cancer. We never look for cancer. If we happen to find cancer, then we should follow up on it. But if we happen to miss cancer, we're not held responsible for that either, because we're not looking for subtle pathology. So why do we want to teach you guys, our students, ultrasound? Well, I've already told you why. The reason why I want to teach you ultrasound, the reason why this center exists, the reason why you have 2 sonographers working for the medical school is that we want to make you guys better doctors. All right? That is the only reason we do this. We want you to be awesome doctors. We want to be proud of our MCG graduates because you know how to do clinical medicine better than the average medical student graduating. And we use ultrasound to help you, all right? We are trying to bridge gaps. How often did you look at that body in the cadaver lab that was splayed open and not get that relationship anatomy? They ask you a question about this structure goes under this structure, and you're looking at these little tiny little things that don't make much sense, because they're all shriveled up, and you're like, what is that thing? Is it really a vessel, or is that just a piece of tissue I didn't dissect? With ultrasound, you can see it live. You can see into the body live. I can show you anatomy. I can show you how everything relates. I can show you physiology. I can help demonstrate differential diagnosis to you so that you make better test selection, that you help get to your diagnosis quicker. And then if you can get to your diagnosis quicker, you can have better outcomes. Now, some of this stuff you're going to perfect in residency, right? Some of these things you're not so awesome at yet. That's all right. If you keep on this road, you will be, and that's what we're trying to do. One of the things that I figured out over time is that by the time you guys get to fourth year, and I could do it to you today, is that you forget some of those things we learned in the first 2 years. And so you start having gaps in your learning. So when I say, all right, everybody put your hand on your kidney, some of y'all will not put it on your kidney, which is underneath your ribs and your back. Some of you will put it down on the side, and that's not where your kidney is. And so with ultrasound, I can help refresh those things in you so that it helps you when you're talking to patients about pyelonephritis or kidney stones. The cool thing about ultrasound is it's common language. So it's just like math. So everybody, it doesn't matter whether you speak Spanish or English or Russian, math is math. Well, ultrasound is ultrasound. And so it doesn't matter what specialty you go into. It doesn't matter how you were trained or when you were trained. Ultrasound is ultrasound. I can show you a liver. That is where the liver is. I can tell you what the liver looks like, and that correlates to disease. And it doesn't matter whether you're a surgeon or emergency medicine or clinical or family practice. So I can help increase your clinical understanding of things that are going on. And like I said before, it's non-invasive and inexpensive, so you can do it as much as you want. You're not going to hurt a patient by using ultrasound. So we want you to do this. And this course that we're doing now is helping you learn how to be skilled, to start getting independent learning with this skill. So you go out and explore. You find out the things you don't know. There are plenty of resources out there for ultrasound. So if you look at something and you're like, I'm not sure where that is, you can go explore it on the internet, on clinical ultrasound websites. There's plenty of them out there. You can find the answers, or you can just ask somebody like us. So we're using ultrasound to help with you correlate anatomy, help you visualize physiology in action, work to specific diagnosis, differential diagnosis elimination, help you make better test selection, help you have better outcomes, and that's what makes you a better doctor. And I know that takes a little bit of faith on your part that that's what it does, but as you go through this year-long rotation, you'll see that you're going to get better ultrasound skills, and when you examine a patient, you're going to be reaching for the ultrasound, but because you're like, well, if I can tell if their bladder's full, I don't need to stick a Foley in them to see that they have urinary retention. I can just see it, and I know my answer immediately, and I didn't go through a nurse. You're going to use it for a lot of things that you didn't understand how not to use it, right? So if you don't have an ultrasound, you have to do things a certain way. When you have an ultrasound, you get to do it a different way, and all of those things make you a better doctor. So there's a lot of barriers for using ultrasound in clinical practice. The education-specific ones are fairly big. But, again, you guys are at a unique place where we've overcome all of these barriers. We've got time in the curriculum. We've got medical student courses like this one. We have sufficient amount of machines for you to use so that you can get adequate practice. Their leadership, whether it's in the academic affairs with the medical school or the dean or in the hospital, they're all supportive of you guys doing this. You know, they give some faculty time commitment. That's me. And there is no liability, all right? There is no liability. You're not doing anything to hurt anybody. So all of these things, these barriers kind of disappear once we get rolling, and we're rolling. So you guys get to benefit. So just one more point. Again, this is a journey through time, okay? This is not something that you're going to do in one shift or one rotation or even in 1 year. This is lifelong learning. So right now, y'all have been through the first and second year, and you may or may not have realized where we were helping you in the curriculum. But we've been trying to help you understand anatomy and physiology and some physical exam skills, and we're going to get better at that over time for the future years of medical students. But when you got into clinical medicine, this year, you know, it was very limited. Next year is much more broad. We were trying to help you with point-of-care ultrasound so that you can understand what's going on in those rotations. So in the family practice rotation, understand what the difference between aortic aneurysm and aortic dissection is. Understand how to screen people and what that means for aortic aneurysms. Because we want to make you better doctors. But again, you know, residency is where you really learn how to practice medicine. And so that is going to be a lifelong commitment to where if you are interested in ultrasound, you're going to have to incorporate it pretty much the whole time. If you leave it for a few months, again, you're going to forget how to do these things, and you're going to be reluctant to use it. But the more you use it, the better you get, and eventually you may become a clinician sonographer. That's what I am. So I use ultrasound all the time. I really don't like it, examining patients if I'm not using an ultrasound. I just, I'm pushing on somebody's belly. I don't really know what I'm pushing on. But with ultrasound, I can see what I'm pushing on. So I like using ultrasound. Y'all might not ever get to that point, okay? Just as long as you guys get an awesome education for the money you've paid, the time you spent, that's what's important. But some of y'all will continue on this journey and get to be awesome at this. So what we've been doing, and this is what our current plan is, this has been developing while you were in medical school, but we're very solidly set in first year medical school. That was several years ago for you guys, but the first and second year now, ultrasound is correlated with the physical exam. Y'all will see that when you come into some of the labs that Becky was talking about. You'll see that we're in there teaching the new medical students, the young medical students, how to feel something and then look at it with ultrasound and how they correlate. It's a little bit different than what y'all had. The third year, we're now integrated in 4 of the rotations completely: surgery, family medicine, medicine, and OBGYN. You guys only had family medicine, OBGYN. And then the third year is the summing up of all those skills, which is the rush exam, which y'all are doing in emergency medicine now. The difference is that you guys didn't have quite the linear experience that the people next year will have and the year after that. So y'all are a little bit of a disadvantage. So please ask questions about all of this as you go along. And there's a new video I just made for the rushed exam, which is kind of cool. I made it yesterday, so very short. But sorry for that not being ready for you guys when you're like having to look on Google to find out what it is. But postgraduate training is really where you develop your clinical sonographer skills. Okay, and that's what you'll get to. Hopefully you'll all pick a residency that has a strong ultrasound program, and y'all will show them what MCG students can do. So, our goal is not to make you guys into radiologists. It never was. I don't want to make you a radiologist. You want to be clinicians, all right? I don't even want to make you a clinical sonographer, even though I hope that some of y'all will become that. I want to build enthusiasm, and I want you to become excellent at clinical medicine so that you are excellent doctors, and that's really what we're shooting for.